Hello. I'm very happy and I'm really honored of being here today to talk at the Congress of the Asociación Argentina de Neurocirugía about some tips in embolization for AVMs of the brain. These are my disclosures. My talk will be about indications, and then we'll follow with strategy, technique, and management post-op in AVM embolization.
I guess the most important thing is indications. And we believe that the endovascular treatment of brain AVMs achieves a low rate of cure and runs excessive risks. This is the starting point. So the indications for us for endovascular approach to AVMs starts with the pseudoaneurysms in ruptured AVMs. As an example, this is a 25-year-old woman with repeated intraventricular hemorrhages that comes to us after some days, and you can see here the remaining blood in the ventricular system. This is the AVM, a very high flow, ugly looking in the frontal lobe of the left side. But what is important is to find the place where the rupture was, and usually this is very easy to see. It's a pseudoaneurysm which can be even a little bit far away from the nidus itself, and often it is in the subependymal space in the. On these images you can see the pseudoaneurysm and the microcatheter going towards it and entering the small branch and finally lodging in the vicinity of the pseudoaneurysm. Here you can see the injection of contrast in the vessel and the glue injection, which accurately reproduces the shape of the pseudoaneurysm. So the before and after show you that once this is done, the pseudoaneurysm is no more there. And this is exactly what we want to achieve with the treatment of ruptured AVMs. A few more examples. This is a hemorrhage in a young person with, again, you can see in the posterior circulation a small central pseudoaneurysm in the mesencephalon, and you can see also here the microcatheter, which is arriving very close to the hole. Another view of the same thing, just to show you the way the microcatheter has to go to get there into a perforator originating from the tip of the basilar artery and crossing the mesencephalon and reaching the posterior part of the mesencephalon. A different example, another ruptured AVM and another small aneurysm that has to be reached through a lenticulostriate artery. And again, a different one, the usual appearance of the rupture point, which is a very small aneurysm, and that's the target of our treatment.
A second indication for AVM embolization is to prepare the AVM for surgery. And that usually means that we may take care of the feeders which are deep or far to reach from the point of view of the surgeon. Here you can see a parietal AVM in the AP view, and on a lateral view injected from the branches of the middle cerebral artery. This is the lateral view of the injection of the posterior circulation, and you can see the posterior cerebral artery, and you can also see what could be a problem at the level of surgery. This branch is a branch which runs through the white matter of the parietal lobe towards the AVM, and it's probably the branch that could be difficult to manage surgically.
Why? Because it runs through the white matter, and once you get to the nidus and you start occluding all the small little vessels, these vessels are coming from behind, are coming from the deep part of the nidus, and often they are difficult to take care of surgically. So what we do is to get there with a small catheter, and here you can see the injection of contrast medium on the left and the injection of glue on the right. In this way we achieve a result which we believe is more helpful for surgery rather than just injecting material into the nidus itself. Another example, you can see very well this callosal frontal AVM, and again, what's more a problem during surgery is what comes from the deep part, and the lenticular striate that you have seen can be navigated. We get very close to the deep part of the and we can occlude it, helping again surgery. The tip here is whenever you have to embolize an AVM, just ask the surgeon what he needs. And this, of course, should be done in advance and, of course, together.
In this case of cerebellar AVM, the target of the embolization are the feeders that are located on the opposite side compared to the entrance point of the surgery. So the surgery will come from behind, from the occipital bone, and we need to occlude the artery which is in front of the cerebellum. So we would inject glue in those arteries, which we believe will be the ones that will help the surgeon.
Here you can see the feeders we navigated and we occluded. Nothing in the nidus, only an occlusion like a surgeon would do just by placing a couple of clips. The CT scan immediately after the embolization shows the location of the glue, which is on the anterior side of the cerebellum, and the CT scan after surgery shows how this is the right way to do it, because the surgeon comes from behind and he operates the posterior part of the AVM. What comes from the anterior part has been taken care by the embolization. angiography after surgery shows the complete eradication of the AVM.
In those AVMs where there are many dilated veins, one of the risks of surgery is to have a post-op venous thrombosis. So it may be an advantage to have an embolization beforehand in order to diminish the flow and to diminish the number and the size of the dilated veins. So in a case like this, where you have several dilated veins, we prefer to have an embolization, and the result is a reduction of the number of veins and a reduction of the size of the veins.
But the tip is don't wait too long between sessions, because if you wait a long time between one session and the other, you may have a development of collaterals, which again are a big problem afterwards. There is also an indication to treat AVMs before radiosurgery, but it's very rare. We tend to only treat aneurysms, especially if they are ugly, or of course if they are pseudoaneurysms. Like in this case of an 11-year-old girl, intraventricular hemorrhage, there is a small deep AVM with a ruptured pseudoaneurysm. She comes to our hospital a few weeks after the hemorrhage. And you can see a very small AVM in the temporal lobe. Again, here on the coronal MR images. Angiography shows that close to the AVM there is a big aneurysm. The AVM is considered to be treatable with radiosurgery, gamma knife, but first we would like to get rid of the aneurysm. So by catheterizing the anterior choroidal artery, you get very close to the aneurysm, injecting glue, and you leave just a very tiny small part of the AVM, which will be treated with gamma knife afterwards. This is a CT scan after embolization. This is angiography after embolization. You can see there is still a small remaining AV shunt. Gamma knife 3 months later on the residual nidus. And 4 years later, you can see the complete cure of the AVM. In some severely symptomatic cases, sometimes we go on and embolize AVMs in order to have a reduction of flow and have an improvement of the clinical situation, especially if there is a progressive worsening, which could be a hemiparesis, which could be an aphasia. Neurologic symptoms can be improved in very big and large AVMs, which cannot be completely resected, but they might improve by a palliative reduction. But what you should not do is what I call the hit and run embolization. So what is a hit and run embolization? It's when you embolize an AVM without a precise target. You just go with a catheter where it is nice and easy. You inject some liquid material as long as you feel safe. You stop soon and reschedule for another session without ever reaching the cure of the AVM. And when you don't know what to do anymore, you tell the patient to go and look for a surgeon or stereotactic radiosurgery. Tip is that hit and run embolization is very gratifying for the operator because it's repeatable many times, it's at low risk, and it's a lot of fun. But it's absolutely senseless and dangerous for the patient. And unfortunately, it's what it's mostly done in the world today by our colleagues. So now we might discuss a little bit about the strategy of AVM embolization. The question could be, should we go via the arterial route or via the venous route? How many sessions should we do? Should we start to attack the nidus or should we start to attack the fistulas? About arterial versus venous, usually today the venous approach is the one which is considered the number one approach to have a complete occlusion of the AVM and a complete cure of the AVM through the endovascular approach. But in most cases of venous approach, we also need an arterial catheter in order to be able to visualize the AVM and to have a better understanding of where we are, what we are doing, how much of the nidus is becoming occluded during the injection from the venous side, and often also to finally occlude the AVM from both sides. Only arterial when, well, of course, when not venous, and probably the indications are pseudoaneurysms or in cases, as you have seen, of pre-surgical or pre-radiosurgical embolization. How many sessions to do? Depending on what is the aim of the treatment. In most cases, one session is enough. More than one session, you have to do it when a major reduction is needed, which is usually rare. But the tip is that you have to beware of repeated sessions, because if they are close one to the other, you may induce radiation-induced complications like alopecia and skin lesions on the head. And if there are many, you may induce radionecrosis or radiation-induced tumors like meningiomas, and that may happen often many years later. If you want to discuss the question, should I attack the AV fistulas first or go to the nidus first and keep the big shunts for later? Well, this is a nice question, but I think that so far there is no real agreement. Most people just go to the fistulas because that's easier and they think it's better, but again, this is not for sure. What about the technique? We might discuss what kind of type of catheter, how many catheters, should we use pressure cooker or mini balloons, should we lower the arterial pressure or use the rapid heart pacing or use the adenosine to have a transient cardiac arrest when injecting glue. We have many catheters today to be able to navigate the brain vessels almost anywhere. In order to inject glue, which is N-butyl cyanoacrylate, N-bucrylate, the best catheter is the Magic catheter, which is a very small 1.2 French microcatheter. Fantastic. It has a perfect navigation, smooth and very safe, even in the smallest vessels. But unfortunately, it is not allowed for injection of the modern liquid embolics. The catheter Magic is very old, at least 30 years old, but it's still wonderful. But if you inject the modern liquid embolics like onyx, fill or squid, it will burst. The tip is use it without a wire. Just steam a little curve on the tip and play with the jet effect of injecting contrast with different pressures and at different dilutions. So you will have a different viscosity inside the catheter and in the liquid you're injecting, and the catheter tip will move differently according to it. But if you have to inject DMSO liquid embolics, onyx, fill and squid, all Medtronic and Microvention microcatheters are compatible. The Stryker catheters may be used too, but they are off-label. And the tip is, if you are in the brain, use only detachable tip microcatheters, which is the Apollo for Medtronic or the Sonic for Balt. Why should you use the detachable tip? I show you this case of a 45-year-old woman. She had this finding of an AVM in the precentral frontal lobe on the mesial surface. You can see the AVM here. This is one of case done many years ago, and you can see the nice cast of onyx inside the nidus, and the 1-year follow-up was a very nice cure of the AVM. But what I didn't show you is that at the end of the procedure of the embolization, we could have on the CT scan this small but obvious hemorrhage, which was due to the traction on the microcatheter at the end of the procedure in order to take it off the vessels. How many catheters should we use? There is no real limit. Now today we may put 2-3 microcatheters in one single guiding cath, and then we may have many different guiding catheters because we can use different arterial accesses, the femoral, the radial, the carotid. And the tip is that you may even put 2 different introducers in one single femoral artery. We do that once in a while, so that really tells you there is no limit in the number of catheters that you may use. Just as an example, here you can see 3 different catheters for this AVM. One catheter is in the middle cerebral artery, this one, which goes along that way. Catheter is in the middle meningeal artery, this one, and that is the corresponding image on the angiogram. And one catheter is in the draining vein, this one, So once you inject onyx in all these three catheters, you achieve the complete occlusion of the AVM. And this is stable at the 1-year follow-up. Should we use a guiding catheter? Yes. All the times you need to go through a venous access. But how far should you go? Well, as far as needed. You may go in all sinuses and also in cortical veins. As an example of this subependymal ruptured AVM, you might see the AVM there. This is the vein of Galen, and this is the straight sinus. You can see the guiding catheter coming up into the straight sinus and into the vein of Galen at the level of the origin of the internal cerebral vein, so that the microcatheter could be advanced into the draining vein of the AVM, let's call it AV shunt, and just a small quantity of onyx was injected to have a complete.
Pressure cooker and mini balloons are recent improvements in AVM embolization, but it's for that reason an ongoing experience. It's a complicated issue and we have different opinions about it. So what is a pressure cooker? It's the occlusion of an artery or a vein to avoid an excessive reflux when injecting the liquid embolic. René Chapot invented the pressure cooker technique, and with that you place coils and you add some glue in order to occlude permanently the vessel. Mini balloons are also an occlusion device, but it's a temporary device. As an example, I just show you what we did in this case, where we arrived with two catheters from the venous side, placed one catheter close to the tip of the vein, and with the second catheter we started to place coils and more coils in order to occlude that segment of the vein, and we added some glue, and finally we could inject onyx in the nails. There is also the question if we should achieve a lower arterial pressure just by lowering it by the anesthesiologist, or we could also stop the flow by using the rapid heart pacing or a transient cardiac arrest. So all these are different methods to control the speed and the distances of embolic penetration, but really we don't think we need them in 99% of cases. We may finish with a few considerations about the management post-embolization, about these topics that you see here. So the question is, should we keep intubated or have an immediate extubation? Of course, if you keep the patient intubated, the monitoring of vital parameters is easier, but the clinical monitoring is lost. So in most cases we prefer to extubate the patient immediately. Heparin post-op, I think it's very important. We are very happy to give heparin for at least 3-5 days, just because we are worried about venous thrombosis. Should we keep arterial blood pressure low and venous pressure low? Yes, this is pretty obvious. We should not have a raise in blood pressure immediately after an AVM embolization. So we come to the conclusions. I think AVM treatment is one of the highest challenges in the neurovascular field, and so I also think that only a complete collaboration and coordination of the efforts can achieve the desired results. Thank you very much.